Well, good morning from Rockville. It's a true honor and privilege to speak with you today. I'm Dr. Van Coots, a physician leader in Montgomery County, Maryland, currently serving as the CEO of Person Clinic. Most recently, for the past 8 years, I served as the CEO of a multi-hospital health system here in the county, and concurrently as the chair of the board of one of the largest Medicaid managed care organizations in Maryland. Community health, the health and welfare of all of our citizens, has always been a real passion for me. Not only ensuring that there is equality and access to care for all, but also that there is real and true equity in the evaluation, treatment, and outcomes so that each person can live the very best version of their lives. The U.S. health system is a highly complex system due to multiple, sometimes competing stakeholders, from hospitals and health systems to insurance companies and payers, to medical groups and the pharmaceutical industry, to the federal government managing Medicare, TRICARE, and Veterans Care, and with the states regulating Medicaid. The patient, who's at the center of all of this, often finds navigating these complexities to be daunting and frustrating. On top of this, for some, the social determinants of health, such as affordable housing, access to transportation, adequate and affordable sources of food, unemployment and job security, and education, also have direct impacts on the health of the individual and ultimately on the community as a whole. In today's presentation, we'll look at the evolution of many of our current health policies, such as the Affordable Care Act. We'll look at telehealth and virtual care, improvements in behavioral health care and mental health services, the rising cost of medications in the United States, innovation in healthcare, and combating drug resistance. Perhaps the most consequential change in health policy in decades was the enactment of the Patient Protection and Affordable Care Act in 2010. With all of its sections coming into force by 2014, the Act set out to make healthcare insurance more affordable and accessible by the majority of the American people. It provides for free preventive care, eliminates lifetime limits on insurance coverage, extends the age limit for coverage for younger adults, expands Medicaid to cover all adults with income below 138% of the federal poverty level, and it supports innovations in care delivery which are designed to lower the cost of health care and increase better outcomes. There's work ongoing to expand its scope, particularly in decoupling health insurance from employment, and eventually to moving the country to alternative models of payment, such as a single-payer system, what is sometimes lumped under the heading of Medicare for All. It's good to note that since the U.S. delegation is from Maryland, in our state, we're under a unique payment system, a special waiver in partnership with the Centers for Medicare and Medicaid Innovation, which for hospitals and health systems creates an all-payer system where all payers pay the same amount for the same procedures at each individual hospital. This eliminates rounds of negotiations with insurance companies, which often leads to confusion for both patients and their doctors on the cost of care and on services. And it creates a global budget revenue system where each hospital knows exactly how much it's allowed to earn inside the regulated hospital space, and thereby stabilizing and controlling prices, expenses, and ultimately revenue. This waiver proved to be protective during the COVID-19 pandemic. Now, while we were expecting CVS, Aetna, Berkshire Hathaway, Walmart, and Amazon to be the great disruptors in the provision of healthcare in America, the real disruptor was the COVID-19 pandemic. It not only broke the U.S. health system, but it exposed problems and issues that had been developing for decades, which have never been adequately addressed. It was a frightening time that I will personally never forget. My health system diagnosed the first 2 patients in Maryland and the 3rd patient attributed to Washington, D.C., all on the 4th of March of 2020. And in the first wave of the pandemic and in the early part of the second, our hospitals cared for more patients than any other health system in the state. All total, during the official period of the emergency, we cared for more than 6,000 COVID inpatients, 5,000 outpatients, and witnessed more than 900 deaths, something only the combat veterans among us had ever witnessed. Early on, we had very little in the way of testing and almost nothing in the way of treatment. Access to protective equipment was subject to the highest bidder and often seemed like something out of a made-for-TV movie. But we also experienced things which we thought would lead to major necessary changes in the healthcare architecture of the nation, beginning with the policy changes that increased accessibility through the medium of virtual care through telehealth visits. Once these policies were relaxed, we were able to care for patients remotely who otherwise were too frightened to come in for care, or who were significantly at risk of COVID due to other underlying comorbid medical conditions. My 4 large community clinics, which normally would see 40 to 50,000 visits annually, actually saw more than 100,000 visits, ensuring that patients that needed to be seen were in fact seen, and thus keeping down emergency room visits, hospital admissions, and in some cases, readmissions. Telehealth works, not just in primary care, but it's been proven to work in specialties such as dermatology and psychiatry, and has even been shown to work in the preoperative and postoperative phases of surgical care, minimizing the need to potentially expose patients to hospital-acquired diseases like COVID and others such as the respiratory syncytial virus. Telehealth acceptance by patients skyrocketed, and we continue as long as it's available and a viable alternative for in-office visits. Certainly not all care can be rendered virtually, but there's a substantial portion that can be done over the phone or via video connections from the comfort of the patient's home and even sometimes from their car. Access to virtual health must become a standard in American healthcare. Policy should focus on permanently expanding telehealth access, ensuring equitable coverage across insurance plans, and addressing licensure and cross-state medical and nursing practice issues to make virtual healthcare more accessible. Another unintended consequence of COVID was the unmasking of the depth and breadth of behavioral health needs in our communities. With this comes the recognition that our behavioral health networks of providers and clinics, including psychiatrists, psychologists, social workers, outpatient clinics, inpatient hospital mental health units, and the nurses to staff them, and community-based crisis beds and acute crisis teams, was all inadequate. New regulations are needed to ensure that the networks are in fact adequate and that patients have access to care regardless of the type of insurance that they may have or their ability to pay out of pocket. In Montgomery County, through a partnership of all 6 hospitals in our county called Nexus Montgomery, we've increased the number of crisis beds in the community and community outreach teams that can help to keep patients out of the emergency rooms and avert a major health crisis before it occurs. Additionally, the county has worked to recognize the special needs of behavioral health and substance abuse patients in the criminal justice system, ensuring that they get the necessary care in the right setting, which often is not in jail. The federal government, in partnership with the states, has brought about changes in Medicare and Medicaid which have benefited not only patients, but also health systems, such as several new unique payment models in Medicare and expansion of coverage in Medicaid. The Consolidated Appropriations Act of 2022 ended the continuous enrollment of Medicaid beneficiaries and began the disenrollment, which was expected to create marked increases in uninsured rates. While this is true to a point, many states have passed some version of the Medicaid expansion provisions under the Affordable Care Act, and thereby covering the gap which the disenrollment created. But not all states have done so. As a reminder, while Medicaid dollars are federal dollars, they are controlled by each of the states. The United States has some of the highest prescription drug prices in the world. Recently enacted laws under the Biden administration have begun to change the landscape in the relationship with the patient and their ability to pay for the drugs that they need. The American Rescue Plan and the Inflation Reduction Act are designed to lower the cost of prescription medications, protect against surprise medical bills and so-called junk fees, and continue to increase the number of Americans with viable health insurance plans. Decreasing the cost of medications for seniors, particularly diabetics in need of insulin, decreasing or eliminating the cost of vaccines, and capping the out-of-pocket costs for prescription medications, which will begin in 2025, are some of the hallmarks of this legislation. Medicare is now empowered to negotiate over the prices of prescription medications for the first time in history, and work is ongoing to protect the special drug discounts under the 340B program, ensuring that those most in financial distress can get the medications that they need. In the realm of data and analytics, artificial intelligence is the game changer, which will eventually lead to more efficient healthcare, better outcomes, and decreased workload for physicians, and other members of the healthcare team. Despite the fear that AI will someday replace humans as healthcare providers, the reality is that it will significantly alter the workflows and increase the speed of diagnosis and predictive ability for long-term outcomes for numerous disease states. There's significant discussion around the world on the ethical use of artificial intelligence and on creating the necessary boundaries. What we need currently are policies that will support the integration of AI and machine learning, particularly in the analysis of health data, in predicting disease outbreaks and mitigating future pandemics, such as geospatial intelligence that can predict community-level health needs, not just to the level of the zip code, but down to the individual block. And of course, in the personalization of patient care, which is the essence of health equity. In the mental health arena, there are several specific areas of need for immediate policy changes. And these are, number one, policies to better integrate behavioral health services with physical health services, including bundled payments that financially support the implementation of team-based care models. Number two, we need to eliminate Medicare's 190-day lifetime limit for inpatient psychiatric admissions. Patients should be able to get the level of care that they need when and where they need it. Number three, we need to repeal the Medicaid Institutions for Mental Disease exclusions, which prohibits the use of federal Medicaid funds to cover inpatient mental health services for patients who are aged 21 to 64 in certain freestanding psychiatric facilities. Next, we need to increase targeted funding for pediatric mental health services. We need to reauthorize key programs in the Support for Patients and Communities Act, which would extend expiring payments, grants, and other programs for substance use disorder treatment and prevention. We need policies that will support innovation in digital health platforms for all mental health services. And finally, we must increase targeted funding to invest in the healthcare workforce, particularly in behavioral health, for doctors, for nurses, and for technicians. And there's a particular need for those who care for pediatric patients, and perhaps this is our greatest need. Looking forward, we have an aging population and a population that will live longer. We will need innovation in geriatric care so that our elders can also live their best lives to the end of their lives. This includes implementing policies that will support hospital at home and will provide adequate reimbursement for the supporting technologies. As chronic diseases account for a significant portion of healthcare costs, innovations like remote monitoring technologies and wearable devices can help manage these conditions more effectively. We also need to bolster patient access to post-acute care, including long-term care, inpatient rehabilitation facilities, and skilled nursing facilities so that patients can get the care that they need, which will allow them to be discharged to home and then monitored from home. Next, I'd like to talk a little bit about drug resistance. So the better our antiviral and antibacterial drugs become, the more they're used. The more they're used, nature has a way of combating them through the development of antimicrobial resistance. These changes over time to viruses, to bacteria, fungal infections, and parasites significantly increase the risk of severe illnesses, disease spread, and death. They also lead to longer hospital stays, more emergency room and urgent care visits, and ultimately lead to significantly increased healthcare costs. Now, while we recognize that it's impossible to eliminate resistance completely, as microbes will always be able to modify their systems and adapt to the changing environment, we must first and foremost develop better antimicrobial stewardship, which is using the right drug for the right reason and not the long-standing shotgun approach to treating infections. And we need this to be transparent and cooperative on a global level. Moving into the future, We also need increased funding for research into newer and better classes of antimicrobials, which will be more targeted to the different diseases and the different disease agents than simply creating more broad spectrum medications. The next pandemic is probably already lurking out there, and it may be driven by drug resistance. And in the realm of pharmaceutical innovation, we must have policies that promote faster and more cost-effective drug development, which includes supporting precision medicine and streamlining the FDA approval process for new drugs and therapies, especially those that are targeting rare diseases. So each and every day, as members of the healthcare team, we have an obligation to recognize that no two people are exactly alike. And for that reason, the approach to a person's health needs must be tailored specifically for them. To truly get to health equity, we need to provide the right care to the right patient for the right reason, at the right time, and in the right place. Only then can we ensure that we have met the needs of each individual to live their best life. Health equity begins in the community before the patient ever reaches a hospital or health system. We must redouble our efforts to mitigate and eliminate those social determinants which are sometimes like hitting a brick wall. We have the technology to reach more and more of the underserved population than ever before. And with AI and machine learning, the possibilities are endless. We must create more community-based programs that truly meet the needs of our populations and eliminate healthcare deserts as much as we work to eliminate food deserts. So that 4G or 5G cell phone that we have in our pockets and purses has more computing power than the computers that were used to put a man on the moon. So let's begin with that and leverage it for all the good it can do to provide access to needed community-based services as well as needed physical and mental health care. And lastly, I would like to end with a word about sustainability and for stewardship of this planet that we all share called Earth. Innovation is not limited to machines and drugs. It must exist in every corner of our healthcare facilities, no matter how large or small, no matter if in a hospital or located in a strip mall. Any location where we see a patient and where we render care must become energy efficient and waste conscious. Increasing policies are being developed which promote more stringent environmental standards and therefore must also support innovation in green technologies in healthcare settings. We must protect the planet for our children and our children's children. We all know that we have the power to do it. So the question is, what are we waiting for? So I hope that this short talk has given us all a shared understanding of some of the issues and a bit of the political landscape surrounding healthcare in the United States, particularly as it impacts community health. We do so many great things on a daily basis, but there is so much more that we need to do. Rather than doing what we've always done and expecting different outcomes, we need to raise our heads and to look up and look to the future. We need to imagine the possibilities, and as we used to say in the military, get up on top of the hill to see the horizon. Thank you all for your time and attention today. I wish you much success and all the best in the final days of this international collaboration. And for those traveling back home soon, travel safe. God bless and goodbye.